Good morning. So as we kind of find our seats and get going here, I've got a few words to say. There is some room actually up in these upper balconies here if you can't find anywhere to sit or if you can't see anywhere standing. This is a very small crowd, so very disappointed in the turnout. This is fantastic. I love it. I'm very happy. So before we get started, I do have a few reminders and a few acknowledgements to make. So we do hopefully have a little bit of time for Q&A this morning. I will be using a handheld mic, and I will probably be on this side. I think most of you know Rebecca, at least by email or by phone. And Rebecca will have the mic, and she'll be over on that side. So if you can raise your hands if you have a question, and we'll do our best to get to as many as we can. But as a reminder, we are done at 9 a.m. sharp. So just quickly there. So for those of you who I have not met before, I am Matthew Hart. I am the CEO of Longwoods Publishing. And we are well into our 15th year of Breakfast with the Chiefs. And this continues to be such a fantastic event, and I really enjoy putting these on for you. So lastly, these events are not possible without the support of our sponsors. And supporting today, we have Zanetta Hirji from Accenture. She helped to support this morning. Mario Longo and others from Life Labs. Cynthia Valentis is from Health Pro. From Hirok, I believe Catherine Galton is here. For Medivy and a future Breakfast with the Chief speaker, Bernard Lord is in here. KPMG, Georgina Black, I believe, is here. And from Santis, Patrick Nielsen is here. And then the Canadian Foundation of Healthcare Improvement is also supported this morning. So that's a lot of support for this morning, which makes it a wonderful event. And without the support of Rotman, we wouldn't be able to put this on as well for providing our facility. And to welcome our speaker, I have Brian Golden. Brian.
Good morning, everyone. It's really nice to see everyone here on a actually sunny spring day, or almost. I'm Brian Golden. I'm the Vice Dean of the MBA programs here at the school and also lead our Center for Health Sector Strategy. If you've never been to Rotman before, you might think of us just as a business school. But over 20 of our 160 faculty are actively engaged in research and teaching in healthcare and life sciences. And if you haven't looked at what you're sitting on a little postcard that reveals our newest program, which is our Global Executive MBA in Healthcare and Life Sciences, which is truly global. I think it's the most unique program in the world in that sense, that takes place in Toronto, Singapore, and San Francisco. So as you leave, if you are sitting on it, please grab it and take it with you. I am really pleased to introduce Helen Angus. Helen Angus was appointed Deputy Minister of Health and Long-Term Care in June 2018. Most recently, Helen served as the Deputy Minister of Treasury Board Secretary and the Secretary of Treasury Board and Management of Cabinet. I take a breath halfway through this. Previously, she was Deputy Minister of International Trade, Deputy responsible for women's issues, and Deputy Minister of Citizenship, Immigration, and International Trade. Helen has also served as an Associate Deputy Minister at the Ministry of Health and Long-Term Care, with responsibility for policy and transformation. Prior to her return to the Ontario Public Service in 2012, Helen served as the Vice President responsible for the Ontario Renal Network at the Cancer Care Ontario. She was also CCO's Vice President of Planning and Strategic Implementation and Vice President of Research and Analysis at the Canadian Institute of Health Information. I'm happy to say Helen is a proud graduate of the University of Toronto and holds a Master's of Science degree in planning. I find that very comforting. Certainly one of the two programs at the University of Toronto to come out of, this is the other one, if you are going to lead our health system. So please join me in welcoming Deputy Angus.
Wow, a lot of you here. That's fantastic. So delighted to be here this morning. Thank you, of course, to Longwoods and the sponsors for hosting the event. Had a lovely breakfast and a great cup of coffee, so much appreciated. I think it's been about 5 years since I was last speaking at breakfast with the chiefs, and I would say a lot's happened in the last 5 years. And I'm without my sidekick, because last time I did this, I was with Matt Anderson, and at exactly about this moment, he looked at me and said, "If it goes badly, Helen, we're just going to hold hands behind the podium." It wasn't a clear podium that day, so anyway, we've been busy, as you can imagine, and getting to know a new government in the early days of their mandate. I did that initially from the Treasury Board platform, so got an understanding of the players and got in early, I think actually on June the 8th. Then was quickly appointed basically to come home to the Ministry of Health and Long-Term Care, and it's been my great pleasure to be back at the ministry. And I would say, again, a lot has happened in the time that I was gone and traveling the world with international trade, and I see a group of both patients and providers who are more passionate than ever about the work that they do. So I'm going to talk a little bit about where the change is. I guess I have to do this myself, eh? Oh, that would be good. All right, now I just turn the thing off. That's fantastic. Okay. There we go. So you can see what the reason for change is, and you probably all know this, working in the sector. We know that, Ontario has world-class healthcare services provided by some of the best professionals in the world, and I think, the outcomes that we achieve are remarkable. But I would say at the same time, many of us, and I would include myself and my family, experience a healthcare system that is at times, disconnected, and that the handoffs between providers really doesn't work along the patient journey. And we've also heard in a number of reports, whether it's the Auditor General or whether it's from our own patient and family advisory councils, and there are now many of them in the sector, they really feel like they're not supported along a care journey, particularly, as I say, they move from one care setting to another. And people tell us over and over again that they have to tell their story and that the information doesn't follow them as their journey continues. So I'm going to talk a little bit about how we're going to try and solve some of those challenges, walk you through the government's plan, understand the values that underline the work on the plan, talk about how we're going to better connect care, because that's what it's really all about, the role of Ontario health teams and what we hope the role that they will play in a transformed healthcare system, and then finally talk a little bit about Ontario Health, which is when the legislation is passed, is going to be the agency that works with the government, the stakeholders, patients, families, caregivers, to try and make the more continuous journey that I think all of us are hoping to achieve. And then really how we're going to create a sustainable healthcare system together. And there is a lot of opportunity here to shape the work of Ontario Health Team oh, there we go, wrong slide. I'll learn this by the time we get through this. So really trying to think about what is the vision around connected care. And for those of you who might have had a chance to see Minister Elliott talk about this, she talks about this with great passion and interest. And I think, talking about how to improve the patient experience in a number of ways, really supporting care providers to organize themselves and work as one coordinated team. And this really is not an idea that the ministry has dreamt up. This is an idea that has come from the sector and has been in many ways the work that you've been doing over the last few years. It's giving it a little bit more structure and animating, I think, the aspirations of the people who work in the sector. Looking at how we can coordinate and make those transitions to become more smooth and organized for patients, and really providing support for patients to be able to navigate the system 24/7. And we're saying that deliberately. We really are hoping that the Ontario health teams will be able to put into place systems and supports that will provide care around the clock for those who need it and access to navigation services. We know that, again, in pockets, we're able to have patients who can coordinate the various different healthcare providers and appointments electronically, and they can book online and do all the modern things that we can do when we travel or bank, but that isn't uniform across the system. We want to have a system where we see people as whole people rather than just as a single disease or condition. And under the plan, we're going to integrate the multiple provincial agencies that actually intersect with the delivery system and really provide a central point of accountability and oversight for the healthcare system so that we're actually all rowing in the same direction. There, I'm finally getting the hang of it. So really focusing on patient care, and again, having arrived back at the ministry, we had a very active and engaged patient and family advisory council, and they've created a patient declaration of values, and if you haven't had a chance to look at it, I really would commend it to you. It's a really important touchstone for us as we think about what is the system that we want to create, and it's really done in the words of patients, by patients, families, and caregivers, and I think it will provide us the guidance to make sure that we're actually doing right by the people that we serve. It really talks about patients as partners, not only in the sort of design and work in the delivery system, but also as partners in their own health. It addresses topics such as respect and dignity, the expectations around empathy and compassion, accountability, transparency, equity, and engagement. And there's a lot behind those words, and they really are phrased as, we expect the system to do these things for us. And I think it's a really important piece of work. And it certainly is guiding our work provincially, and I hope that it will inform, the evolution of Ontario Health Teams and the individual interactions, the millions that happen every day in the healthcare system. So first of all, I would say, transforming a system is a big change. For those of you who know me, I used to have the NHS change model in my office just to remind me how complicated this is and how we have to pull all the various levers to make a change that is big enough that one would call it a transformation. We know that's a long-term proposition, and we need to continue to consult with our partners and stakeholders to ensure our collective success. And so really we're just beginning. And I would say that we are continuing to engage with, as I mentioned, the Minister's Patient Family Advisory Council, as well as the Premier's Council on Improving Healthcare and Ending Hallway Medicine. And they've been incredibly helpful advisors to us and will continue to be as we kind of plot this journey together. For those of you who like that sort of thing, the legislation is out there. It's actually, I guess there's hearings yesterday and today where organizations are making deputations on the legislation. There's some very good ideas have come forward about making that legislation better. So we'll see if we can accommodate some of those, if not all of them. But I'm pleased to say that in the preamble as well as in the legislation, it really talks about the recognition of the diversity of Ontario's communities, including acknowledgement of the requirements of the French Language Services Act and the unique role of our Indigenous communities. And so if passed, the legislation would see the creation both of a French Language Health Services Advisory Council that will respect the role of the French language planning groups, as well as potentially more than one Indigenous Health Council, really to continue to advise the minister about the health and service delivery issues as it relates to their communities and making sure that our solutions are customized to the needs. So I'm going to talk next about Ontario Health Teams. I must say this is an idea that has animated the sector, and I'm mindful that 5 years ago I was here talking about health links, and I think very much that the work that was done on health links is actually informing the work on Ontario Health Teams. Ontario Health Teams give them, I think, a little more structure, wants to clearly cover the province at a point in time, but also has a lower rules environment and ability for providers to shape the solution to their particular geography or population. And I think, what's quite exciting for us is I know everybody's waiting on the guidance material, and I'm hoping that that will come out before the end of the week. But as a practical matter, I think we've received 4 or 5 Ontario Health Team proposals, and we haven't even sent the guidance material out. So somebody's excited about something, which I think is great. Obviously, we've been talking about this for a while. The legislation does describe it in the broadest sense. Some might be critical of us in terms of not coming up with a master blueprint and a very prescriptive model for how Ontario health teams are going to work. But I actually like the fact that it can be, we're going to set the outcomes, and we're going to be quite dogged about what the outcomes are and some of the expectations about improvements for patients. But we're not going to be as prescriptive about the governance and the organization as long as providers are working together. And for those of you who read these things, it wasn't that long ago, in the last couple of weeks, there was an article by the King's Fund that described some of the attributes of successful integration efforts, and it really is about relationships. And so, one of the things we're going to look for is, do you have the relationships in place to be able to actually partner together and to support each other to really work as one coordinated team for patients. And so, at a minimum, we're hoping that a team would be comprised of, primary care, hospital services, mental health services, home care, long-term care, and others. And I'll go back to, some of the thinking around the most complex patients, because that clearly is still part of the Ontario Health Team idea, is that there's still an opportunity here to connect better with other social services beyond health. And the experience we had with Health Links, which I imagine will be repeated here, was it didn't take very long for the health tables to start merging with the community support tables and the justice tables as they were looking at whole people. And I think there's a real opportunity here to do that. And so really these integrated teams are intended to provide a full range of health services to patients. And here's the list. And really streamline navigation for those who need it. And so some of the work that Walter Woodchis has done around sort of segmentation and looking at the population, I think will be very helpful to the work of Ontario Health Teams. Like accountable care organizations and some of the other models that we've looked at around the world, the team will be held clinically and fiscally accountable for delivering a coordinated care, continuum of care to patients. And so, we're going to have to look at how we fund, how we organize ourselves as a ministry in order to be able and enabled to do that. So really, Ontario health teams are going to be responsible for understanding, a patient's healthcare needs and history and connecting them to the different types of care, and really deal with, some of the transition points in the organization of care that have proven to be problematic for many Ontarians. It really is about, seamless access to care, easier transitions from one setting to another, the comprehensiveness of the service, and then really, and part of the reason why we've, and I'll get to this, have put the digital health capacity with the clinical organization inside Ontario Health is to make sure that patients have access to digital tools such as virtual visits and digital access to their own health records. And there are jurisdictions that do a whole lot better than we do in those areas, and I think it's time that we actually started to modernize the delivery of healthcare in a way that patients expect. So we're also hoping that care providers will also benefit. So this is, I think, a win for everybody from the expansion of digital tools as well. So enabling them to move quickly and comprehensively to get the information they need, such as special advice and clinical supports. Again, we've got excellence in pockets, and we've got some areas of the province that are using those tools on a regular basis, and some are not. And so how do we make that a regular feature of the healthcare system, I think is a challenge ahead of us. I think really it's the, we've got some work to do to enable the funding and accountability. We have great experience with bundled payment. This is kind of a new frontier for us in terms of really kind of developing a funding model for a whole population of patients, and then allowing the Ontario health teams to actually move the money around to best suit the needs of the patient population that they're trying to serve. And so again, the lower rules environment that was part of Health Links is very much part of the Ontario health teams, the value proposition there. We know that there are terrific examples already of providers coming together to provide a coordinated, connected patient care. And I think that we've got, a chance to really animate, the sector to take all those good ideas to actually spread them across the province and make that much more available as a regular course of business for patients. So what does an Ontario Health team actually look like? As I mentioned, it's really not one size fits all by any means. We're hoping that emerging health teams will consult with their local communities and determine how best to organize themselves to meet those circumstances, including First Nations, Métis, Inuit, and Francophone populations. We also know the geography of the province is vast and varied, and I'm reminded, from my time at Cancer Care Ontario, that Northwestern Ontario is the size of France, and so the solutions that are going to work in Northwestern Ontario are not the ones that are going to work in downtown Toronto. And so the governance and the organization has to be, I think, customized to the characteristics of the population and the geography that we're trying to serve. And so this is really an opportunity for providers to take the lead on what they're doing and organize in the way that best achieves a set of outcomes that are going to be identified in the guidance material in the coming days. Also just want to talk a little bit about how does one become an Ontario Health team, and there's kind of been a big rush and people are worried about getting in the door early. I would say we're taking a very organized and stepwise process. So they will be established in phases across the province. We will provide guidance and we'll provide a tremendous amount of support to ensure that the Ontario Health teams are successful. This is, I think, would say, there are opportunities, for us to leverage the ministry's data assets, the clinical leadership that exists in the province, the research, the health services, analysis and other things to really make sure that you have a running start on creating a health team. We're not going to place particular restrictions on the types of health providers and the organizations that are going to apply, but they have to meet the minimum requirements that are critical to success. And we're hoping that over time, that initial group will actually grow and include more providers. Really, we're looking at, again, providing, coordinated care, and the process will be, there'll be initially a self-assessment. So are you ready? Do you have the relationships, the data, the understanding of the population? Can you commit to doing this? And so it's really a moment of reflection to figure out whether, a community actually has got all the ingredients to do this. Based on, an analysis, some will be invited to submit a full application, and others will be suggested that they've got some more work to do. And again, we'll continue that relationship as they work through their Ontario Health Team proposal. We actually want to go out and see them. I guess we want to see the relationships. We want to see how it's actually working on the ground. And so part of the assessment process will be an in-person visit with the whole team and see how that actually feels to us and make sure that everybody's really on board for working together differently. And then, even those that don't make it necessarily in the first round will certainly continue to receive our support to become ready. And it's going to take us a few years to cover the whole province, but the intention is very clear that we want Ontario Health teams to be a regular feature of the delivery system in Ontario. We will work together to get there. Our hope is that the small group of early adopters that we hope to identify by the summer will be part of our kind of teaching capacity so that the others will learn from the first cohort. And obviously, the way that we work with the first group might be a little different than the way we work with the last 10% who might have other sort of relationship and other issues to get there. But I would say, there's great enthusiasm, and it really is because this is an idea that comes largely from the sector. And our job in the ministry is to really animate it and make it make sense in its implementation. So I'm going to talk a little bit about Ontario Health. This is probably the part of the plan that's received a lot of the attention. Although I would say that Ontario Health teams are really the ground game for transformation. So Ontario Health is really going to bring together the many provincial agencies that offer clinical guidance, evaluation, public information, health sector analysis. And many of these organizations have world-class standards and methods of implementation that the government is hoping to replicate and amplify across the system. As you heard from my biography, I did that while I was at Cancer Care Ontario in terms of taking the methods that CCO has used to great avail in the cancer system and applied those into the world of chronic kidney disease. And I think there's still opportunities. And think about, we're on the cusp of, probably unprecedented investments in mental health services, and thinking about, the provincial apparatus that would be required to really support, high impact investments in mental health services, or the methods that are very similar to the things that Cancer Care Ontario built over a decade. And it won't be done in a day, but I think that there's an opportunity here for us to really make a difference in diseases and conditions that actually impact large patient populations that do not have the same kind of provincial infrastructure that some others do. There's obviously been, some discussion about, is there a trimmer way to do this? And each of these agencies has, a full senior management team and back office supports. I think, at the end of the day, we will have strong verticals in cancer and in renal care as examples, but there are some opportunities to streamline, some of the common functions across the various health agencies. We're starting to do a bit of asset mapping, and just recently on the real estate side, I can tell you there are 158 leases or properties within the portfolio of agencies that are going to be rolled into Ontario Health. That's a lot of leases and real estate to have in the agency world. So that's the kind of thing that I think we need to look at. Are there opportunities to consolidate and look at the footprint of the agencies and get some more value from the government's investment, and not necessarily work in those verticals, but also across silos. And so we did a lot of thinking at the beginning about, did we want to have a clinical agency, an agency that would focus on digital health, and an agency that would kind of look at getting more value out of procurement. And then we kind of gave our head a shake and thought, yeah, but actually digital is the way that healthcare is going to be delivered, and so why would we not want to have our digital resources closest to our clinical resources? Why would we not want to have our clinicians and our clinical leadership telling us more about how we can buy things that actually make the most sense? So we really wanted the clinical side of the house to be starting to drive as much as we could on the digital and the procurement. So one big agency seemed to be the right way. It's a challenge, for sure, and I will say that, we will stand up this agency in a thoughtful way in phases. And so just because the legislation is moving along at a clip doesn't mean that on the date of proclamation that everything is going to fold in on, the 1st of July into the agency by any means. The idea is that we can proclaim in phases, we can make sure that we've got a management structure that makes sense, that we can migrate agencies in a phased approach that actually is, respectful to the important mandates that those agencies provide. And so that's our commitment. And I know the Board of Ontario Health, which is not yet a Crown agency, it's actually a not-for-profit corporation until the agency is, the legislation is passed, is very seized with making sure that that is done in a very orderly, stepwise way. So that's very much part of the thinking. And so really, let's go back here, is that, the plan is based on building, bringing the best of what we have, and again, scaling those up across the system. And part of Ontario Health Teams that really excites me is that they're organized service delivery, but they're also knowledge transfer nodes, right? If we have 30 to 50 Ontario Health Teams across the province, we'll have probably a better idea about how we can get information across the system. We want to improve access to secure digital tools, and we really are trying to catch up to where patients are telling us that they want from their system. So I see Matthew here. You probably want me to stop and answer some questions. That's okay? All right. And I think, Ontario Health will play an important role in overseeing this transformation with the ministry. If we could do this all on our own, we probably would have done it before, but we actually need the capabilities of our agency to really enable, performance measurement, performance management, clinical guidelines, and really help us support the providers to work in a different way. And it really is going to help us provide a common approach to integrating care and really, improving and I think elevating our accountability and oversight of the system. As I say, it brings together the digital assets that exist in eHealth Ontario, although I think we really need to build out a stronger kind of consumer health digital presence, and that's definitely sort of part of the initial planning, even within eHealth, as they start to prepare for this transition. And I think really, you know, it is about moving forward with speed and impact, but as kind of as practical and as a kind of stepwise way that actually makes sense for the system. So taken together, we're really looking at, you know, as I say, closing the gap between what people want from the healthcare system and what we actually deliver. You know, our job in the ministry, and it will change once we have Ontario Health Teams up and running and once we have an agency with the kind of breadth of mandate that it will have. Our job is to set out the expectations, the consequences, the rewards of delivering high quality care without necessarily being the micromanager that has characterized some of the work of the ministry. And, you know, I've certainly been part of that, and it's probably our natural inclination, but we actually have to find a way to pull back and really focus on outcomes. The intention is to put the resources and decision-making closer to patients and really enabling innovation across the healthcare sector. And as I look out in the room, I see, you know, leaders who are fully capable of embracing this change, and it's very heartening to see all you here today, and know that you have a willing partner in government, and I know you'll tell us when we've got it right, and I know you'll tell us when we've got it wrong. So, and actually, we're all in this together, so I really appreciate that very much, and happy to take questions. Thank you. Great. Well, you know, Doris is the first one who wants to ask a question.
So if you do have a question, raise your hand. Rebecca will be on this side. I will be on this side. So I assume that we have just a few questions.
So, Helen, you have heard the question and I have heard the answer, but I think it's, for others, maybe interesting. And I presented yesterday on the bill, and the biggest concern, because quite frankly, we were supportive also of the LINs at the time, RNO, and we asked for the actually dissolving of the CCICs. Our only and biggest concern is that the same mistakes that happened with the LINs happen now, that we only do the restructuring, but we don't focus on clinical services. And by that specifically, I mean the beefing up of primary care. 10,000 nurses already are working in primary care and are not working to full scope by no means. And 5,000 or 4,500 are sitting in the offices in the LINs. We asked at the time that they need to be in primary care. We're asking the same again. Yeah. They need to be in primary care.
We're not going to have an argument about this here, but I would agree that, you know, there is a whole discussion to be had about what the right location is of care coordination. If you think about all this moving closer to patients, it has to move closer to where the patients are. And that means in the clinical setting. I've answered Doris before on this, largely, but maybe not exclusively, primary care. I can see care coordinators working in community support agencies, actually, in addition to primary care. I can see, you know, and again, we'll reflect on other conversations. There are also, you know, I said hospitals, you said, Helen, there's already a lot of discharge planners in hospitals, so I've listened to you. So I think, you know, there's an opportunity here to really look at what care coordinators do and make sure that they're really adding value and working in a very connected way with the whole clinical team. And that means all the resources that are assembled to work together in Ontario Health Teams to really make sure that they're making a difference for patients. You know, I happen to have, you know, the dubious benefit of having, you know, two parents who have been on home care and seen the multiple assessments, seen the role of the LIN care coordinators, the coordinators that work inside the health service provider, asking questions about what other services could be provided beyond the LIN provided services, and being a little frustrated myself. That may be an N of one, and it's not driving policy by any means, but I think it's a real challenge for people to actually get the services they need and feel that their care coordinator is really part of their team.
I actually have a question as well. So on Friday, I posted an opinion from Matthew Anderson. and he discussed housing.
You're supposed to be here.
And he discussed housing, and I've also heard about transportation and other ministries and other sectors, and I just wonder how we avoid the infighting.
Yeah, so I'll go back to, what was sort of the fantastic thing that I took away from some of the work on HealthLinks was, anybody here from Waterloo, but at Waterloo it didn't take very long for the HealthLinks table and the community safety table to actually merge, because they realized that they were dealing with the same population. And if you go back to this, whether it's Ontario Health Teams or HealthLinks, and Ontario Health Teams I think is a more evolved idea than HealthLinks, you could see how, many of the stories that came from that, it was actually community transportation or housing that would make a difference to a whole trajectory of care. You could get this much health service, or you can get this much health service and some housing and some community transportation, total cost being less, but actually having more impact for people. And so I think as Ontario Health Teams actually evolve and start to connect and really focus on patients, that those needs will naturally emerge. Our job in government is going to be to try and catch up, but the minute we start to see some money moving around patients to actually support them with non-health services as a substitution, I think that will be a day where I'm pretty happy, because I think that's kind of, we're not having the whole system move that way, but certainly some that's around patients. So that will be, I think, a victory for us, and to show that it actually can work. One of the things that I didn't talk about is that Ontario Health will have regional presence, so it's not all being centralized into, Toronto, for example. There will be regional offices. They won't be doing exactly the same things as the LHINs, but we're very much hoping that the geography of the Ontario Health Teams will actually be the same geography as some of our other ministries, which is kind of a start. And this is, sounds kind of bureaucratic, but this has proven elusive, to actually have government departments all planning on the same unit. And many deputies have tried to actually crack that. We now have a chance here to actually work in the same geography as our colleagues in children's and community and social services. And again, I think that will bring a little bit more natural coherence to some of the work that we do around populations.
So Helen,
hi Andy.
Hello, good morning. So you're quite right, there's extraordinary enthusiasm groups across the province, and my question relates to a bit of a granular aspect, or at least theme. A lot of times when people begin talking about what they're going to do in their organization with partners to develop either an OHT or just the general concept, sometimes the conversation devolves to current legislative barriers, whether it's PHIPAA or Placerta, et cetera, et cetera. I wonder if you could comment just in a general sense, not necessarily specifically, as to how we as healthcare leaders ought to frame these perceived or real barriers, and how we work together with government to make sure that these are not getting in the way of excellent progress.
Thanks, that's a great question. So I would see them as kind of speed bumps, but not barriers. And what we want to do is actually know what, I think we know what some of them are, and you just gave two. But I think, what are the things that are getting in the way of truly integrated care? We need to actually work alongside the whole, as a system transforms, to basically start to remove those barriers. And, some of them turn out to be policies, and those are actually pretty darn easy. Some of them are legislation, and we have a chance several times a year actually to introduce legislation in budget bills and the fall economic statement and other things to actually remove those barriers. Denise Cole has been basically charged with doing this. She's just leaving the ministry now, but we've already done some work on the barriers that have been brought to us. So I think this is a constant and iterative process, which is why we need to work so closely with the Ontario Health Teams, is to figure out what are the things that are really in the way. I would say, there are some discussions to be had with the Information Privacy Commissioner, because we need to be able to move information around the team a whole lot better. We need people to be able to work as a team, and how do we enable that in a way that makes sense for everybody. But I think there's a whole lot of other ones, and we're a little bit rigid, so we're going to have to, it's going to be a learning experience for the ministry to kind of get out of being kind of rules-based and process-oriented to become outcomes-focused, but we will get there.
So Helen, it's a great transition. I want to pick up on this setting goals and providing minimum specs. And I'm really quite pleased when you talk about accountability, both the upside for Ontario Health teams and the downside if they don't meet their goals. The systems that have done something akin to this across the world have a history and actually a skill set of actuarial skills. And if I were a leader of an Ontario Health team, I'd be quite scared right now going to the ministry and saying, I'm going to take this on because I don't know enough about my population, how to risk adjust, what a reasonable payment model would look like. And that seems to me to be an area that we need to substantially develop in the province in order to take some of the risk, not accountability, but take some of the risk away from these Ontario Health teams. So can you talk about that?
Yeah, I think we're going to have to learn to, that through the early adopters and actually, so I agree, there's payment models. We're going to have to up our game on analytics for sure. I actually am quite interested in predictive analytics and looking at artificial intelligence and are there opportunities there to actually see around corners and to start to sort of model out populations and impacts. And I think about my time in renal care where we had 20% of our patients were crash starts and other people were being followed by nephrologists, for decades and weren't progressing. So how do we actually kind of more closely connect the resource with the needs? We're looking at opportunities for, better costing information as well. I think that's a real challenge is actually using our costing information as a management tool, and there are places that do a better job than we do. So all of that has to be kind of part of the picture. I would say that's an excellent job to ask Ontario Health to actually do some work on our behalf. I think about, again, the depth of resource in analytics that's at Cancer Care Ontario, the relationships we have with Walter and some of the other scientists in the province. I think we need to actually throw out a challenge to them about how to do this better. And the Ontario Health teams will actually demand it, right? And so, we're not mature enough in every part of this to scale this up today. I think it's a journey for us, but you hit the nose on the whatever. Hit it on the nose. That's exactly what we need to do. Hi, Adriana.
Hi, thank you. I'm Adriana from the Alliance for Healthcare Communities. I'm really pleased that you made the comment about Bill 74 and the commitment to equity in the preamble. I'm hoping as part of the hearing, we're going to be there today, that it actually moves into the objects. Because we know if it's in the preamble, but it's not in the objects, it doesn't have the legislative weight. So, one of those improvements we'd like to see. A couple other comments. You talked about care coordinators. 50% of Ontario's primary care providers today have access to interprofessional teams. And so 50% are ready right now to take the care coordinators. We don't need to wait for the Ontario Health teams to do that. And I really urge you to think about how you can move those into the teams that are ready now. We don't need to wait. And we've been asking, we've got partners sitting here right now who really are ready for that. So I wanted to kind of make that comment, but there's no place to take that. There seems to be an emphasis on doing it at the Ontario Health teams. I don't think we have to wait. Yeah. So that's the second point. The other and final, and it relates to funding, and I'm glad the question was asked, but we have right now, and I'm really, really happy that you're talking about relationships and the importance of relationship building, but there still is a huge power imbalance with these very large hospitals and small community groups. Even though the community groups have the trust, they have the relationships, but the hospitals have the VP of integration that they're hiring, the huge money to bring in big consulting companies, and so just wondering how you're going to deal with the imbalance that exists. And my final point, because I don't have it. Yep. You said, yeah, I know, I only have one chance, right? So bundled care, you talk about funding from a bundled care perspective, and I know there was a lot of learning, but when you're dealing with primary care and chronic disease, bundled care is not actually, I don't understand how you can use episodic care that's bundled care and translate that learning to lifetime primary care, care coordination, mental health addictions, chronic conditions. And so the same question about how you're going to do this funding, I think is going to be really critical. And every time anybody speaks to it, they say, but we've learned from bundled care. And I can't, they're different. And yeah, so I'm trying to understand that a little bit.
Yeah, I think the lessons around bundled care for me are more about there might be some technical parts of it, but it's also just about the relationships that have been provided. And actually, it's probably the learnings have been maybe the most profound for us in terms of starting to get out of siloed thinking inside the ministry about how to basically follow patients across a journey. So I think, you know, it's given us some muscle memory inside the ministry about how to work differently with the sector. On the imbalance, you know, I think we're going to have to be vigilant about this. I know Doris has some very firm ideas about how we can address the imbalance, you know, whether it's money, whether it's additional support, whether it's initially making sure that the very few that are the early adopters, the leaderships are coming from different places. You know, and I'll go back because it's sort of fresh in my mind. I've been thinking a lot about the Health Links example. We did have Health Links that were developed by, you know, Wood Green and that were not even health service providers at the time. Those are pretty interesting, right? And so, you know, we're going to see what works, but, you know, I don't think this is going to be kind of one model that's, you know, hospital out and that we need to allow for different approaches and see what actually produces the outcomes that we're looking for. And if we have to put our thumb on the scale a little bit, we will. And see, you know, what that looks like. Because I think we want to try, you know, so it is a process of learning, and so I think we want to try some different approaches, and certainly community-led, and you know, we have Tariq Azmi in the minister's office, so we have somebody who's, you know, actively has run a CHC. We have some CHC and family health team expertise on the board of Ontario Health. So I think, you know, you've got people there who actually are looking out for the community side of the house, because it's that part of the system that really has to actually do a lot of the heavy lifting around Ontario Health teams.
Thanks, Helen. So the vision and the change.
All my friends are asking questions. Hi, Lisa.
but hopefully kind questions. Okay. The vision and the changes are pretty exciting for the potential for Ontario. And we also know that, you know, structure will help and it'll get some of the frustrations out of the way. But healthcare works today because of the people who work in it. And they work around the challenges, right? They're very endeavorous, they're innovative, and they're very committed to people. So what message would you have for the people working in the system as the macro system makes these changes?
I think, you know, first of all, you know, there's a message of, you know, calm and stability. It all sounds very big, but, you know, we've been telling organizations, you know, keep doing the work that you're doing that actually, you know, impacts patients. And if it's good work, you know, it obviously, you know, has great value. So, you know, keep your head down. But I think also for frontline providers, that's where the emphasis in this whole transformation is. So hopefully there'll be, you know, more opportunities for you to collaborate, you know, be part of, you know, Adriana's point, half of the primary care providers don't work in interprofessional teams. Ontario Health teams are actually interprofessional by definition. So, you know, you will have more connectivity and more resource at your avail to, you know, basically do the job that you want to do working with your patients. So I think that's kind of the message. It may take a while to come to your community but there are opportunities to get involved now in creating it, right? So for those who kind of have an interest in being, you know, in sort of working through these issues and figuring out the relationships in their own community, there are so many tables being set up. I, you know, kind of see on Twitter that there are meetings happening across the province, again, in the absence of the guidance information. So clearly, this is something that, you know, people want to work on, and if they care about their patients, they should find a, you know, a receptivity to their inclusion and you know, their contribution. So I think it's kind of a heyday for them. I'm hoping it is, that it's actually something that really, you know, makes them feel that their work is valued.
Hi, I'm Jean Schmidt from Centre de Santé Communautaire Hamilton, Niagara.
Oh, hi.
Nice to see you again. I met you with the Health Links a number of years ago because I was a Niagara Southwest Health Link lead.
That's when that picture was taken too.
Exactly, yeah. I thought I recognized the slide. I just have a couple of questions, but firstly, so we have a Francophone community health center in a very English world in Hamilton and Niagara. And to date, the accountability for other agencies to provide services in French, even in the French designated regions of Welland, Port Colborne, and Hamilton. So the accountability framework thus far has been that these agencies need to have a French language service plan. So I just want to kind of speak on behalf of our staff and all of our clients to let you know that a French language service plan is just that. It's a pile of papers where service providers can check, I've got my FLS in place, but it doesn't provide any services. So when I go home today and I'm speaking with my staff and I'm speaking with my clients, what can I tell them will be different this time around, given that you've already indicated that you want to be governing at an arm's length? You really want to let communities kind of figure it out and do it their own way to best serve the clients. So far, no one in the community except for us has really fought for French language services, and we're really the only show in town that actually provides services in French. The Welland Hospital has a sign on each and every one of its doors saying, here we speak French, but the signs don't provide services because no one inside the building speaks French. So I want to go back today and say, I went all the way to Toronto, I got up at 6 in the morning, I had a little quiche, and I've got some news. So what would that news be?
So I think the news is that, first of all, you need to look at the guidance materials that are coming out on Ontario Health Teams, and they will be out before the end of the week. All things being equal, hopefully, within the next couple of days. So that will be helpful. But I think you actually have an opportunity when you see what the expectations are, is to continue to advocate and be embedded in the governance of an Ontario Health Team in your area that actually continues to drive improvements in access to services for the Francophone community. And so I think you have a chance to shape it there, and we can, it's clearly an expectation in the legislation, and we will support you to be able to do that. So, and I think you have to look at how then you deploy the resources that you have within your organization, across the population, and maybe you have to reach into the hospital and find a new relationship with them in order to be able to serve Francophones when they're in the hospital. But I think you've got to work on what's going to work locally. But that commitment to those populations is very much part of the legislation, and I know Adriana will talk about that this afternoon.
Hi, Helen. You said something about Susan wanting questions from your friend. So I'm just wondering what the current thinking is on the defined patient population, because I think some of the early feedback we're getting is try to concentrate on a geography, but there's also like some really interesting opportunities to actually concentrate on a group of people. For example, in Toronto, we've talked about women, because we have a hospital, we have organizations in the community. So what will the guidance, tell us about that?
Yeah, so I think of Ontario Health Teams as largely a geographic concept, but not entirely. We have what I guess informed our thinking was a very interesting proposal that predates the sort of the brand of an Ontario Health Team that came from CHEO. So CHEO, Children's Hospital of Eastern Ontario, is the hospital, is the children's treatment center, and is the home care provider. Kind of interesting, right? So you've got a confluence there of three, kind of providers all in one organization, and they kind of developed a proposal which, again, could look at pediatrics there and probably have some critical mass in order to be an integrated, delivery organization. Now, whether that, is exactly on brand for an Ontario Health Team, the other thing I would say is there's opportunities to improve connectivity and integration that may not be an Ontario Health Team. It's not the only thing we're going to do. So, I think we want to be flexible. We originally thought, I guess the literature suggests, 300,000-ish is kind of a good number to do the risk adjustment and other things that Brian talked about. But, that's not going to work in Northern Ontario. It means the whole of Northwestern Ontario is one Ontario Health Team. I don't think that's a viable proposition. So context matters, I think, and all the work that you would do around sort of integrating care around a population you have to see whether it really fits with an Ontario Health team, but it might be worth doing regardless. And so I think that's the kind of discussion that we need to have, and we need to look at the metrics that are going to be suggested that everybody work towards and see whether that idea can actually forward movement on those metrics and make sure that we're not leaving people behind.
We have time for one more. Any takers?
Totally clear.
Might be your last chance.
I doubt it. They're all going to, well, we're going to have lots of conversations about this over the coming years.
Well, with that, oh, we do. Here we go.
Thanks. My name's Andrew Williams. I work in Southwestern Ontario in a group called the Hermperth Healthcare Alliance. And first of all, thank you for your leadership. I think change is always challenging, but it's important. And we're all committed to doing what's best for our patients and the communities we serve. My question is a bit granular. The health teams are voluntary. Lots of information yet to come. Is it the vision of the ministry that all health service providers will ultimately be part of a health team, or will there be flexibility in sort of how you approach various regions and streams of care?
I think at the end of the day, if this proves to be beneficial to patients, then the intention will be to have all Ontario health providers be part of a team. And I think the guidance material will say that quite clearly. And so, at some point, it becomes problematic for organizations to sit, or a whole geography to sit and be an island where, we're not going to collaborate and coordinate around the patients if it actually proves to be really, truly beneficial. I know, there's some pretty interesting ideas actually, in your neck of the woods. So, we're a ways away from making it mandatory. We want to work with the early adopters, but again, if this is really has the promise that it has, I think we've all got to work towards it to cover the province. Yeah.
So as you're gathering up and getting ready for the rest of your day, our next Breakfast with the Chiefs is April 30th. It'll be moderated by Will Falk and will feature Arden Crystal, the President and CEO from Southlake, with Brendan Carr, the President and CEO from Osler. And they will be discussing health system reform and lessons from BC. So that's April 30th. Other than that, have a fantastic morning. Thank you.